You're welcome to my channel. I'll be talking about locked-in syndrome. Please kindly check my channel for Lazarus syndrome if you haven't, so that you can match all the scenarios together. Locked-in syndrome. In locked-in syndrome, we are glad to let everyone know that this is a very rare situation, but that doesn't mean we don't find it. Anytime we find it, something is intact. The cognition and the consciousness will be intact. The supranuclear ocular motor pathway will be spared, but voluntary muscles will be paralyzed. The features will continue to present like the individual can move eyes vertically with intact rostral brainstem. He or she can make facial expressions, can blink. And don't be deceived, he or she can think. They can see you, they can hear you. They know what you are doing. And they are wondering, why is she treating me like this? Why is he treating me like this? Oh, this is a nice doctor, this is a nice nurse. Oh, I could hear all the discussions, the word around medical jargons being discussed around them. They can hear you, they can see you, they can think. They can have sleep and wake times with intact reticular activating system. Reticular activating system has inhibitory and excitatory parts. They can retain a small degree of limb, head, or tongue movement. So you can find them to be stiffen, shivering with dystonia postures, that is scissor-like movement. As a matter of fact, some erroneously diagnose them with seizures and jab them with a loss of anti-seizures medication. They can have some involuntary motor phenomena like bobbing, crying, trismus, groaning, oral automatism, facial grimacing. It can be yawning, coughing, or laughing. But they can't walk. They can't talk. Though they can hear you, they can process what you're doing, but they can't talk. They can't swallow easily, so they have swallowing difficulty or dysphagia. They can have horizontal eye movement. Remember I said they could have vertical eye movement. The respiratory muscles, lips, tongue, and soft palate could become paralyzed, meaning medulla or lateral tegmentum of the pons is affected. They can't breathe normally, so they need your assistance, mechanical ventilation. Swallowing is difficult, like just said in the previous slide, and of course, I've earlier said they won't be able to speak. Now, what are the possible causes here? So, causes of brainstem injuries here will include brainstem lesions like corticospinal, affecting the limbs and trunk movement, corticopontine from cortex to the pons, or corticobulbar, affecting the cranial nerves and muscles, and of course brainstem tumors. So, in the pons, the pontine injury could be central pontine myelinolysis. You can check my channel for that. Another name for that is osmotic demyelination syndrome. When you have anomaly with sodium and you correct too rapidly, then you run into trouble. Check my channel for that. Osmotic demyelination syndrome, already published. Pontine problem could be as a result of hypertension causing pontine hemorrhage. Pontine abscess, ischemic stroke affecting the central or pyramidal base of the pons. Other causes could be hemorrhagic stroke, just like I've alluded to earlier, basilar artery thromboembolism, trauma, toxins, cocaine, or heroin, in other words, street drugs. What are the possible differential diagnoses here? Login syndrome, coma, vegetative state, catatonia, amyotrophic lateral sclerosis, akinetic mutism, polyneuropathy, myasthenia gravis, and metabolic encephalopathy. You can check my channel for login syndrome, vegetative state, and myasthenia gravis. How can we make diagnosis here? Thorough history that will guide us through the clinical features. And of course, full physical examination with full neuro section of the physical examination. And what are the laboratory reports? Complete blood count, glucose, liver function test, renal function test, thyroid function test, clotting profile, and so on. And sometimes lumbar puncture if you are suspecting that there is central nervous system infection. And of course, radiological imaging, magnetic resonance angiography, CT angiography, EEG, and so on. How do we treat locked-in syndrome? Check the airway, breathing, circulation. Create a code for yes or no with eye movements. Nowadays, things are better because of technology, computers, head sensors, high gaze sensors, and voice machines could be used. Still on treatment, we have to treat specific cause, right? Like thrombolytics for ischemic stroke, antibiotics for infection, and surgical drainage for hemorrhage. Still on treatment, physiotherapy or psychotherapy as may be warranted, respiratory therapy and speech pathologist, and of course, refer to rehabilitation centers. Prognosis. Many people in locked-in syndrome will remain impaired and severely so. Some will regain some level of function later on. A tiny percentage will have a good recovery. It's not a good situation that anyone would like to find him or herself, but to those that are there, wishing them all the best, know that they will belong to the tiny percentage that will have a good recovery. With that, I've come to the end of this short presentation. You will not be able to appreciate this presentation fully without going through Lazarus syndrome, vegetative state, brain death, and apnea test. And check my channel for all of them. They are right here. Thank you. Remember to subscribe. Remember to share this presentation. I appreciate that.